Hi, everybody. Welcome to Matters of the Heart, hosted at the Wellness Institute. We have several cardiac residents who will be presenting 3 different topics. They are e-cigarettes and the heart, menopause and cardiovascular disease, and sex and cardiovascular disease. And the residents will introduce themselves when they do the presentation, so you'll get to know who they are. I'm Tanya Kazera, the director of the Wellness Institute, and I hope that you enjoy this presentation. I would also like to introduce to you on my left-hand side, Shelley Sargent, who is our new clinical manager, who will be doing the closing remarks for this presentation. So enjoy, and I hope you learn a lot. Thank you.
Yes.
This was the.
Nope, just the arrows. Sorry,
Just the arrows. Okay, perfect. I'll do it for you.
Oh, sure. Okay.
All right. Good afternoon, guys. I'm Dr. Phyllis Sin,
I'm Hilary Bews.
and we will be presenting our topic today, which is about e-cigarettes and the heart. So we wanted just to include an acknowledgement slide, just about where we are presenting today and where we exist right now. And to start off, the presentation outline will be as follows. We're going to be talking about what exactly are e-cigarettes. We'll talk about what the cardiac risks are specifically, and then we'll mention briefly about whether or not they would be a good implement to use to quit smoking or transition out of smoking. So our first topic is, what are e-cigarettes? Well, e-cigarettes come in many different shapes and sizes, as you can see from the graphic. Essentially, e-cigarettes heat up a liquid into an aerosol, and that is inhaled. We unfortunately don't know all the chemical compounds that are incorporated into e-cigarettes, but most have a battery, some sort of heating element, and a place to put the liquid. So I just wanted to highlight here that e-cigarettes come in many different names, and they come in many different visual forms as well. We've listed a few here above. They're also known as e-cigs or e-hookahs, electronic nicotine delivery systems, tank system vapes, mods, and vape pens. And there are more names that we haven't even included here, but they're just very heterogeneous, and there's just so much variety of them out on the market today. One thing we do want to highlight is that an e-cigarette is still an e-cigarette bottom line. Doesn't matter really what appearance they are or how far away they look like from a general cigarette, it's still a cigarette. In terms of the actual chemical content, I did want to highlight that e-cigarettes mostly contain nicotine in most of their liquids and other substances as well. As you can see here from the graphic, e-cigarettes create an aerosol. That's the main delivery system. And within those aerosols, there are a number of different chemical compounds, all of which change and differ depending on which product you consume. From the graphic here, you can see that some e-cigarettes contain cancer-causing chemicals. There are flavoring compounds such as diacetyl, which has been linked to vaping lung disease that was very prevalent amongst the youth a few years ago and quite dangerous to your health. There's also heavy metals such as mercury, nickel, tin, and lead, ultrafine particles, volatile organic compounds, and of course, as we had mentioned before, nicotine. So Hilary will talk about the cardiac risk.
All right, so we'll just switch positions here. So talking about the cardiac risks. So before I start off, we need to differentiate whether or not these cigarettes are being used for recreational purposes or for smoking cessation. So first what I'll talk about is just use for recreation, and then the latter part will be using them for smoking cessation. Okay, so the other thing to just point out before is that there's sort of 2 types. There's some e-cigarettes that are regulated, and there's some e-cigarettes that are not regulated or that you can modify yourself. And it's important to know which ones you're using because the risks can differ. So what exactly are the risks of the heart? Well, number 1, we're still learning about the long-term effects. So e-cigarettes are relatively new to the market, and so long-term effects are relatively unknown. The second point is that I mentioned all products differ and they continue to change. And because of that, it's very difficult to study them and to learn their long-term effects. So because these products continue to change, we don't know what these even newer products are doing to our long-term health. The next point I wanted to point out was the regulated versus unregulated. So as I mentioned, it's important to know which ones you're using. And specifically, if you're modifying them yourselves, there's probably not a lot of safety data about those products. And then finally, as Phyllis pointed out, there are compounds in the e-cigarettes that can become addictive. And so if you're using these for recreational purposes, that can lead to, further use down the road. So some of the effects that e-cigarettes can have are similar to smoking, although probably not quite as severe. So they can do things like increase your risk of blood clots. They can impair your blood function, and they can also cause stiff blood vessels and decrease blood flow through the body. And so because of that, when they've looked at studies, these are some of the things that have been linked to e-cigarettes. So it can cause things like high blood pressure, heart failure, it can cause heart attacks, dangerous heart rhythms, strokes, and sudden death. There was one study that looked at about 70,000 adults, and daily e-cigarette use was associated with an increased risk of heart attack. This is just a reminder, we're focusing obviously on the heart today, but this is just a reminder that e-cigarettes can have effects on other body systems. So particularly in younger people or adolescents, it can affect the brain development. We've all heard reports of severe lung injuries from e-cigarettes. A lot of that though is the products that are modifiable or not regulated, but there are reports out there. We've talked about the heart. There are some behavioral effects, and sort of addiction would be one of those. It can have effects on your immune system. And the other thing to keep in mind is the poisoning risk. So if there are young children around, it's important to make sure these products are safely locked away. And then this is just a slide to point out that in younger people, especially, e-cigarettes can serve as a gateway to traditional smoking or tobacco smoking. So in 2019, there was a self-reported use of e-cigarettes, and looking at the age range, so people in grade 9 to 12, they reported about 27% used e-cigarettes. The number I was shocked with was that grade 6 to 8, the number was even 10%. So a lot of these younger people are using e-cigarettes. The graph on your right-hand side is showing that cigarette use over time, so times on the bottom, percentage of people using these products are on the y-axis. You can see over time the use of actual tobacco cigarettes is decreasing in young people, but the use of e-cigarettes is on the rise, as we might expect. Okay, so that was primarily talking about more of a recreational use of e-cigarettes, but the question arises, even though there are some risks with e-cigarettes, can they actually help with smoking cessation? And so, the question is, are e-cigarettes safer than traditional tobacco smoking? We all know that traditional smoking is associated with multiple health effects. We've all seen the pictures, and it's actually the leading cause of preventable death. But are e-cigarettes safer? And certainly the media would have us think that that's how they're advertised. They're advertised to be a safer product. So what does the data say? Well, they've looked at studies comparing sort of nicotine replacement therapy, so that would be the patch, the lozenge that many of you might be familiar with, and they compared them with using e-cigarettes as a smoking cessation tool. And what they found is that they're probably a little bit better than the nicotine products. So when they looked at a group of 100 people, 3 more people in that group will probably quit smoking due to using the e-cigarettes versus the nicotine products. So it's not a very large number, but there was a trend towards a slightly more effect in these studies. The one thing to keep in mind is that these studies are quite different from one another, and there were some flaws within the study design themselves, but that was sort of the overall message. Some things to keep in mind though, before sort of just jumping to e-cigarettes as a use for smoking cessation, is that when they looked at 1 year out of using these products, more people are likely to still be using the e-cigarettes than the nicotine replacement products like the patches and the lozenges. So you can see the numbers are quite drastic. So it's about 80% will still be using e-cigarettes versus about less than 10% will be using the patches and the lozenges at 1 year. The other thing to keep in mind is that People using e-cigarettes often will become dual users. So in these studies, about a quarter of people will become dual users, meaning they'll smoke the traditional cigarettes while also using e-cigarettes. And we don't know if those affect each other. So that may cause more health risk on top of what you're already doing. And then finally, there is some controversy whether or not the motivation and the support in these clinical trials is what sort of drove the effectiveness of e-cigarettes. So the question remains, in a real world setting where you don't have as much motivation and support as you would in a clinical trial, are these products still as useful? And this is just a diagram to show that there's probably some degree of risk to all of these products, but it's on a varying degree. So at the bottom is your highest cardiovascular risk, and that would be your traditional tobacco cigarettes and cigars. Somewhere in the middle, e-cigarettes will fall, and their safety will depend on whether or not they're regulated, whether or not you're modifying them. And then somewhere at the top is your nicotine replacement, gums, lozenges, etc. You want to take back over?
For sure. Thanks, Hilary. So in conclusion, bottom line is e-cigarettes aren't safe for youth, young adults, those who are pregnant, and individuals who aren't using any sort of nicotine therapy or aren't smoking at all. There may be a role in using regulated e-cigarettes in the form of smoking cessation, but we don't really know all the health risks. So we'll say that there's not without any health risks. It could lead to dual use, as Hilary mentioned, using both e-cigarettes and cigarettes in conjunction while they're trying to quit. But we would always recommend you touch base with your healthcare provider because everything has to be individualized to each person's care. Lastly, we just want to drive home the point that we really don't have a lot of information about this, so additional research is really needed to give us all the information we need. Thank you so much.
Thank you very much. So our next presentation here we'll go for is the heart health and menopause. Let's open this guy up here. And we'll do start.
Oh,
Of course.
I'll have to change that again. There you go.
There we go.
Hello, everyone. I'm Dr. Liane Arcinas. I'm one of the cardiology residents at the University of Manitoba,
Dr. Krishnan, I'm also one of the cardiology residents at the University of Manitoba.
and we'll be talking about menopause and heart health. We know that this is a very important topic, and majority of the women in the audience here are women. But we also want to emphasize with our male audience here how important it is to know about menopause and heart health. And hopefully you could share the information that you learned today with the women in your lives and talk to them about the risks that they might have once they reach menopause. Before we do proceed with our talk, we also want to acknowledge that we are in Treaty 1 territory and that we are committed in working with Indigenous people in promoting their rights and responsibilities and also their health. So without further ado, I'll move on to the next slide. Let's see if it's going to play.
It's changing on that one.
It's changing over here.
Oh, it's changing over there, but not here.
Here. Let's quickly zoom slideshow in. How's that?
Oh, there it is. Okay, so we know that heart disease is the #1 killer for both men and women worldwide, but we do know that coronary heart disease tends to occur at a later time for women, about 10 years compared to men. And we do know that the risks for heart disease tend to increase once women reach menopause or after menopause. By the age of 50 years old, women's risk for heart disease increases dramatically. So you might be wondering, how do we define menopause? What are the stages of menopause? So this is just a graphic here showing to you the normal reproductive life of women. As you see here, on the y-axis is your estrogen level and on the x-axis is your age. Women typically have the highest levels of estrogen during their normal productive life, which we call premenopause. And then eventually the estrogen levels go down until you hit menopause, wherein you achieve your last period. And that's when the estrogen levels in your system become very low, as you don't need it to produce eggs anymore. Once a woman is no longer able to have menstrual periods for a total of 12 months, that's when we tell them that they reach menopause, and any period after that is called postmenopause. Normally, menopause is reached at around 45 to 55 years old with an average age of 51 years old. But if you are someone who had some removal of your ovaries, then you will reach menopause earlier, and you might reach it earlier than 51 years old. And studies do show that those who reach early menopause or have surgical menopause also have the same increased heart risk as women who naturally achieve menopause at 51 or 50 years old. So that's that. So you might be wondering, at the age of 50, the heart disease accounts for about half of all the deaths of women in States and in Canada. And during and after menopause, a woman's risk is higher, especially when they have certain risk factors that puts them at risk of heart disease. And that includes these: diabetes, smoking, high blood pressure, high cholesterol, obesity, history of preeclampsia during pregnancy, high blood pressure or diabetes during pregnancy when you're younger, and a family history of heart disease. You might be wondering how menopause is associated with heart disease. We do know that estrogen helps protect a premenopausal woman against heart disease. And during menopause, there are several changes that are occurring in your body in relation to the hormonal changes. And Dr. Nolan will talk more about that in his next part.
Okay, so just like Dr. Sin is saying, we're going to go over some of those changes that occur more frequently after menopause. So one of the big things we see after menopause is that there's cholesterol increase in women. So the low density lipoprotein, or LDL cholesterol, which is considered our bad cholesterol, it can increase by 15 to 25% after menopause, and this is a result of the reduction in circulating estrogen levels. The total cholesterol level peaks in women at 55 to 65, and that's about 10 years after we see the peak in men. So the graphic down there at the bottom is showing the cholesterol levels in men versus women throughout their lifetime, and as you can see, the men in the dark green, they sort of peak around 35 to 45 years of age. And then women, you're seeing a peak later at 55 to 65, and sometimes can reach higher levels, if not equivalent levels. The other thing is we do see a relationship between weight gain and menopause. So obesity is more common in men until the age of 45, and then after that, it becomes more common in women. Weight gain does seem to be more related with age as opposed to menopause status. However, what we do see is the body composition changes are associated with menopause. So with menopause, we see increase in fat deposition and a decrease in lean muscle. And we also see differences in where that fat is deposited. So pre-menopause, fat accumulates in women more in the hips, and after menopause, it accumulates, more likely to accumulate around the waist, which is more like what we see in where fat accumulates in men. And this can lead to increase in waist circumference. And what we do know is that increased waist circumference does reflect cardiovascular risk. So women with a waist circumference of greater than 80 centimeters, we do see an increased risk of cardiovascular disease. And there's an even greater increase in cardiovascular risk in those with a waist circumference more or 85 centimeters or more. So going through some of the other cardiovascular or heart disease health factors. So what we can see is we do see changes in the blood vessel characteristics. So one thing that we can note is that there's increased cholesterol buildup in the arteries in the perimenopause period. And the arteries also tend to become more stiff after menopause. The other thing is we note that high blood pressure develops more commonly in women compared to men after the age of 45. Also, diabetes can develop in women after menopause because of changes in insulin secretion and insulin sensitivity, so changes in the way the body can deal with sugar. Women with diabetes are 3.3 times more likely to die from cardiovascular disease than women without diabetes, so it is a very important risk factor to be looking at and trying to modify. And so Dr. Arcinas will
We'll
continue.
switch again. So as you know, for women, menopause is a natural part of women's aging. And so it's important that we control all the other risk factors that you could modify to prevent heart disease. So we're just going to quickly talk about that here. So one of that is smoking, and this is very important, which Dr. Sin and Dr. Bews already talked about. But we know that smoking increases your risk of dying from heart disease and your risk of having heart disease, and that even one cigarette alone is associated with a higher risk. And we highly encourage our patients, if you are smoking, to talk to your family doctor or your cardiologist regarding quitting. And if you don't smoke, don't ever try it. Next one is obesity. As Dr. Nolan mentioned, obesity tends to be, or deposits of fat in your body tends to change during menopause, and we see more central obesity. And central obesity is when your fat is just mostly in the belly, and we know that central obesity is associated with a higher heart risk. So we found that if your waist centimeter, like your waist circumference is over 34.6 inches or 88 centimeters, that's associated with a higher risk of heart disease in women. That's even smaller if you're a South Asian woman or a woman who is indigenous. The cutoff points are actually lower. And we do know that by the age of 40 to 59 years, about 42% of women in the States are obese, and that's defined as a BMI of over 30. Of course, sedentary behavior does not help in decreasing your heart risk. So we do also recommend that patients be active, and Dr. Nolan will talk about that shortly. Diet. So certain types of foods tend to promote more central obesity. And so we also highly encourage that if you do, improve your diet, is try to have a higher intake of plant-based fats and oils, and to try to avoid any processed foods. And then in terms of cholesterol, for women over 40 years old, in American studies, they found that about 30.4% of these women have high cholesterol, and that's also even more common in certain ethnic groups as well, particularly in South Asian women and also in Hispanic women. Blood pressure is also very common in our menopausal women, and they found that if you are over 60 years old, you tend to have a less better controlled blood pressure compared to a younger counterpart. And that every 10 millimeter increase in your systolic blood pressure is associated with a 15% increased risk of heart disease, both for men and for women. Diabetes is also another big risk factor. As Dr. Nolan mentioned, menopause tends to be associated with a higher risk of developing type 2 diabetes. And these are the interventions.
Okay. So obviously with all these risk factors for contributing to heart disease in postmenopausal women, we just want to review some of the ways that you can modify these risk factors to help improve your heart health. So we'll go through some of these. So exercise is a big part, and we really do encourage at least 150 minutes of moderate intensity exercise every week. Healthy diet is a big component, so pursuing a healthier diet, looking in general at less fats and a high fruit and vegetable content in the diet. Controlling blood sugar and cholesterol So checking your blood sugars regularly if you're diabetic and screening for diabetes, and taking your diabetic medication if you are diabetic. And then focusing on lowering cholesterol through diet and medications as necessary. Controlling your blood pressure, so checking it regularly and making sure it's under control, working with your primary care physician to decrease it. As Dr. Sin was saying, if you smoke, trying to stop smoking, one of the best modifiable risk factors, and nicotine replacements can be helpful to increase success. And if you don't smoke, don't start now. And then screening for other medical conditions can be quite important. So the two big ones that we've been really touching on are high cholesterol and diabetes. So making sure that you talk to your doctor, your primary care physician, about screening. So the recommendation is that women over 40 or over, or menopausal, if they have reached menopause before the age of 40, should be screened for high cholesterol. And women who are 40 or older should be screened for diabetes every 3 years, or more frequently if there's increased risk factors for it. And we wanted to touch very briefly on hormone replacement therapy. We could probably do a whole talk on it itself, but we just wanted to touch on it quite quickly here. So hormone replacement therapy might be helpful for some of those perimenopause or menopausal symptoms. We do know, as we've been talking about, there's increased cardiovascular risk in women after menopause. But so far, there's no data to suggest that hormone replacement therapy is protective against treating heart disease. And so it's not currently recommended for that use.
And I guess we just want to end with a summary point. Menopause itself does not cause heart disease, but it marks a point in a woman's life wherein their heart risks accelerate. So it's very important for you to focus on your health at this point in your life. Thank you.
Are there any questions here online? Questions, focus? Nope, not yet. So let's set the third presentation. See if I can get it right the first time here. Sweet. I think we can start off. Okay, well, thank you everyone for allowing us to talk to you about during Heart Month. So I'm Dr. Sandeep Krishnan. I'm one of the cardiology residents, and joining me is Dr. Evan Wiens. And we'd like to talk about sex and heart health. We have no conflicts of interest to disclose, and just want to acknowledge that we're gathered today on Treaty 1 territory. Go to the next slide. So sex is a modest full body workout. And for those with heart conditions, it is important to consider some of the effects of sex on the heart. And this can lead to anxiety for people, for both partners involved, and may affect one's relationships. And now, talking to medical professionals about this, about when can I have sex safely, may be uncomfortable, but it is important to discuss and acknowledge, and also create a safe plan. There are other reasons besides heart disease why sexual function and sexual drive may be impaired. That can include side effects of medications, that can include anxiety, depression, etc. So sex is a form of exercise, and from the Heart and Stroke Foundation, we typically recommend that if you're able to walk about 2 flights of stairs without experiencing chest pain, any dizziness, or significant shortness of breath, it's probably safe for you to have sex from a heart perspective. Now, every patient is different. So one of the caveats with that, I would say, is to discuss this with your primary care provider, your family physician, or your cardiologist. And part of a healthy lifestyle, which includes regular aerobic physical activity, a healthy diet, can also help improve your sexual drive and function.
So what are the benefits of having sex, and what are some of the risks, particularly with respect to people with heart disease? So there are some important benefits to having sexual activity, and it's obviously an important aspect of quality of life for many people. We do know that among men, the risk of prostate cancer is actually decreased if they ejaculate 2 to 4 times per week. And so there's some, not the strongest evidence, but some evidence that both sexual frequency and also the quality of sex that you have is associated with lower blood pressure, lower stress levels, and also overall reduced cardiovascular risk. So there's some potential benefits. There are risks, however. In patients who have angina or other forms of heart disease, but particularly angina where you have chest pain if you exert yourself or when you try to move, because sexual activity is a form of exercise, it can bring on that chest pain. Now, if you're having problems with chest pain during sex, sometimes taking some nitrates before sex or being on a beta blocker can help to reduce those chest pain symptoms and allow you to enjoy sex more fully. It is important to note that if you're a man taking something like Viagra or Cialis or Levitra, to never take it in conjunction with any form of nitrate. So that would be a nitroglycerin patch or spray or tablets of any form. There is a mildly increased risk of having a heart attack, and this is among anybody in the 2 hours after sex. We know that your risk of having a heart attack is about doubled in the 2 hours during and after having sex. But when you compare that to the entire time of your life where you're not having sex beyond those 2 hours a day, the risk is not that much higher. And certainly most people who have sex don't have heart attacks, and most people who are having heart attacks don't have them after sex. So it's a pretty safe activity as long as you know your limits. There are no particular medications that seem to reduce the risk of having a heart attack with sex, although it's important that to be on all the regular medications for your heart that reduce your risk of having a heart attack overall. It is studied and known that if you exercise regularly, your risk of having a heart attack during or after sex is cut in by more than half. It decreases the risk by more than 50%. So just yet another benefit of regular exercise. You should talk to your doctor if you're planning to initiate or resume sexual activity if you have risk factors for heart disease. So this would be high blood pressure, high cholesterol, diabetes, if you smoke, or if you live a sedentary lifestyle. If you have angina or chest pain with the exertion, if you've had a recent heart attack, particularly in the last 8 weeks, if you have reduced heart function or congestive heart failure, or if you've had a stroke in the past or have problems with the arteries or veins in your leg or arms, these would all be reasons to talk to your doctor before resuming or initiating sexual activity. You probably shouldn't have sex, at least until you've seen a cardiologist or been cleared by a cardiologist. If you have new angina, if you're starting to get chest pain that's new or worse than it was before, or certainly if you're having chest pain at rest that isn't getting better with nitroglycerin. But certainly if you're having chest pain at rest that's not getting better with nitroglycerin, you shouldn't be having sex and you should probably call an ambulance. If you have uncontrolled high blood pressure, you should wait until your blood pressure is under control before having sex. If you have stage 4 heart failure where you're short of breath all the time, it's probably not safe to have sex. If you've had a heart attack in the last 2 weeks, or if you have severe valvular or hypertrophic heart disease, and your doctor will tell you if you have severe valvular or hypertrophic heart disease.
So I'm just gonna finish the last third of this presentation talking about some of the cardiovascular medications. So beta blockers are commonly medications that we prescribe. And one way to know if you're on a beta blocker is if the last few words, if it ends in olol. And some of the more common beta blockers that we use are bisoprolol, carvedilol and metoprolol. And they're primarily used in heart health after one has had a heart attack, in heart failure, or an irregular heart rate condition called atrial fibrillation, and in some cases in high blood pressure. There is some evidence that about 5 in 1,000 people experience sexual dysfunction as a side effect, either erectile dysfunction, low sexual drive or libido. Now, one thing that I would like to draw your attention to is the effect known as the Nocebo Effect. And what that means is that from the common knowledge, beta blockers may be known to be associated with sexual side effects, and that might increase one's chances of experiencing this side effect, the knowledge itself. Another class of medications that may be implicated are what we call the mineralocorticoid receptor antagonists. And those medications are commonly spironolactone, and in some cases, eplerenone. These are used in people who have heart failure or cirrhosis. And in men, we know that it's associated with overdevelopment of breast tissue, known as gynecomastia, and decreased sexual drive. In women, it may lead to breast enlargement, breast pain, and decreased libido. And if you are experiencing that, you may be switched by your family physician or cardiologist to eplerenone, which is that other medication. A final class that may be rarely associated with side effects are the thiazide diuretics. And these are primarily used to treat high blood pressure and in some cases, heart failure. And they're the common ones above that you'll see are hydrochlorothiazide, indapamide, and for heart failure, metolazone. There is association with erectile dysfunction in males and decreased libido. Unfortunately, it's not well studied in females, so the current effects are not known. Now, the medications to treat erectile dysfunction, Viagra, Cialis, Levitra are the trade names. They may be used safely in people with heart conditions who experience erectile dysfunction. And just like Dr. Wiens was saying, we recommend against the use of these medications when combined with a nitrate medication. So the spray, the patch, or the nitrate pill. And you should not take it within 48 hours, not take nitrates within 48 hours of taking one of these medications. And finally, if you're having chest pain and you call 911 and you've taken one of these medications, please let the emergency medical team know that you've taken that medication so they don't administer the nitrates, which can cause a precipitous drop in your blood pressure. Finally, many cardiovascular medications, beta blockers, some of the other medications that we prescribe lead to improved survival and help the heart to heal after an event. And we recommend that you don't withhold them unless directed to by your physician. And working with your physician on ways to resume intimacy safely is important for you. And we do know that most of the time sexual dysfunction is not caused by the medications, It can be caused by cardiovascular disease in itself, anxiety, depression, and the nocebo effect that we talked about. So it's multifactorial. And please inform your physician if you're experiencing any sexual side effects, and together they can work with you on getting to the root cause of what side effect you're experiencing, deciding to change medications safely, and also considering some of the medications we talked about earlier for erectile dysfunction, if that's one of the effects that you're experiencing. Thank you very much, and I wish you all a happy Heart Month.
Let's see, is there any questions here online or in person here? We did have one question for the first presentation here. If we can ask a question about that. So someone's asking about smoking cannabis. Is it as much of a risk as the e-cigarettes, would you say, or is there much known about this, or is this all kind of estimates or guesses at this point? Yeah, if you just want to come up here, then.
Do you hear me okay?
Yeah.
Yeah, okay. Great question. It's one that we commonly get from many of our patients. And it's a question that we get about marijuana and other forms as well, edibles, oils, THC, etc. But the mainstay is that we don't know what marijuana, the actual compound THC, CBD, does to cardiovascular disease. There have been some trials that show that it causes extra platelet clotting, so it makes your blood clot more, and that's very important to know for patients who have had heart attacks or people who have had blood clots elsewhere in their body. The other thing is that, bottom line, you're still smoking something. So the fact that you're incinerating something, you're inhaling that smoke, there could be some unknown carcinogens that we're not sure that you're inhaling into your body as well. So in my experience, I don't recommend my patients to smoke marijuana, and if they choose to use marijuana, I recommend other methods. What about you, Dr. Bews?
I agree with what you said.
Okay.
That's all said.
Thank you very much. Okay. So that, other than saying great presentations, everybody, there's no other further questions. Oh, sorry, in person here.
If you have any information in terms of the connection between menopause and heart disease and hypothyroidism.
I guess the quick answer from my perspective on hypothyroidism is no. I don't think I know exactly what will be the connection between menopause and low thyroid levels. And what was the first part of your question, sorry?
Any connection between hypothyroidism?
Oh, I see.
Or not.
I see. I get your point now. Okay.
Menopausal women with heart disease.
I think what you're trying to get at is if there's different levels of thyroid hormones in your body, if it's particularly low or particularly high, that could affect your menstrual periods, and that could affect your the regularity of your periods per se. But I don't think there's a direct connection between, you know, being low thyroid and being in menopause. I think in terms of age points, it should still be about the same, especially if you get replacements. And then in terms of heart disease, thyroid, having high thyroid and low thyroid also comes with its risks in terms of impacts to your blood pressure, impacts to your sugar level. So all the other risk factors that we talked about that could increase your risk of heart disease could be affected by the level of thyroid hormones in your system. So actually a good question. Now that I keep talking about it, it's all just like it's becoming a big umbrella. But that's a good point. So our topic was mostly focused on estrogen and menopause, but other hormone deficiencies or too much hormones should probably be something to be talked about with your family doctor, and should probably be checked, particularly if you have issues with your thyroid. Hopefully that answered your question. Thank you.
So the Wellness Institute would like to thank our wonderful presenters here today. There was a lot of really great information that was shared. Thank you to our attentive audience present in our facility and those of you joining online. Thank you to Darren for his technical support and all the work you did behind the scenes. A recording of this session will be available on the website within the week, so you can review it again or you can share it with your family or friends. I think we'll call it a wrap. Thank you, everybody.